Yes. Uh, Good morning. Today we are going to talk about decurrence tenosynovitis, also called as DQ tenosynovitis. Okay. See this tenosynovitis. Tenosynovitis is the inflammation of tenosynovial sheath, which is tenosing, and inflammation is also occurring the synovial sheath. It is named after Swiss surgeon Fritz D. Kurban, who first described the condition in 1985. It's a stenosing tenosynovitis. Stenosing means decrease in the circumference. The tendon usually passes through the synovial sheath, or also called as tendon sheath. If the tendon sheath gets stenosed and inflammation occurs, and that we will call it as stenosing tenosynovitis, which affects the tendon sheaths of the first dorsal compartment of the wrist. We'll see the first dorsal compartment of the wrist in a short while. So it is characterized by the degeneration and the fibrosis of the tendon sheath. Whenever the inflammation occurs, it is usually followed by the degeneration and the fibrosis. That's the climax. So talking of the incidence, it occurs most often in the individuals aged between 30 and 50 years, and it affects females more than male. Okay? It's commonly associated with the dominant hand. If the person has the right hand as his dominant hand, it usually affects his right wrist, the right hand. We'll see the anatomy, and earlier I told you about the compartments in the dorsal aspect, not in the ventral, it's the dorsal aspect. We have a separate compartment in the ventral aspect also. Okay. So dorsal aspect of the wrist contains 6 compartments that transmit the tendons to the hand. What are the tendons? These are all the extensor tendons. Okay. So the first compartment will comprise of abductor pollicis longus, extensor pollicis brevis, and second compartment consists of extensor carpi radialis longus and extensor carpi radialis brevis, and the third compartment comprises of extensor pollicis longus and extensor, and the fourth compartment extensor digitorum and extensor indicis, and the fifth compartment comprises of extensor digitaminum, and sixth compartment comprises of extensor carpi ulnaris. So here we will be more concerned with first compartment, that is, which consists of abductor pollicis longus and extensor pollicis brevis. You can remember it by APL and EPB. APL, EPB. Abductor pollicis longus and extensor pollicis brevis. So where exactly it is located? If you know the surface anatomy, if you want to know, it is approximately 2 centimeter long and is located over the radial styloid process proximal to the wrist. Oh, there is a problem in this slide. Actually, it's proximal to the wrist. Okay. So we'll see the anatomy of both the muzzle. Okay. And as we have seen, there are 2 muscles in the first compartment. I mean, the tendons of the 2 muscles pass through the first compartment, APL and EPB, abductor pollicis longus and extensor pollicis brevis. Abductor pollicis longus originates from posterior shaft of ulna and the radius, and the site of insertion is at the base of first metacarpal. It is supplied by the radial nerve, and its action is abduction and extension of the thumb. As the name suggests, it's abducting the pollicis. Pollicis means with thumb. We shall see the anatomy of extensor pollicis brevis. It originates from the posterior shaft of the radius, inserts at the base of proximal phalanx of the first thumb, first ray, and it is supplied by a radial nerve. Its action is extension of thumb. As the name suggests, it's extensor pollicis brevis. I apologize for the spelling mistake here. So, what are all the predisposing factors? Otherwise, etiology. Okay. So, first, the most common cause is overuse injury. Overuse in terms of wringing the cloths or any repetitive movements involving the wrists. Okay, repetitive tasks that involve overexertion of thumb, radial and ulnar deviation of the wrists, especially, and arthritis of the wrist joint or carpometacarpal joint, and the pregnancy. These are the predisposing factors here. And some activities, some repetitive tasks which aggravate the DQ synovitis are wringing out wet cloths, long use of computer mouse, use of scissor and surgical tongs, texting, hammering, knitting the cloth, lifting heavy objects such as jug of milk, taking a frying pan off the stove, or mother lifting a baby out of crib. It all involves extension of the thumb, radial or ulnar deviation of the wrist. We will come to the etiology and the mechanism. Okay. The tendons of abductor pollicis longus and the extensor pollicis brevis are tightly secured against the radial styloid by a overlying sheath known as extensor retinaculum. Acute or repetitive, more often it's a repetitive trauma that restrains the gliding of tendon results in inflammation of the synovial sheath. Whenever there is inflammation, there will be edema, and this increases the friction, and the end stage of any inflammation, as you have seen earlier in your studies, it's reactive fibrosis and thickening of the sheath. So whenever there is a thickening and reactive fibrosis, the synovial sheath gets stenosed and more inflammation occurs. So actually this results in a vicious cycle of inflammation and the fibrosis. So this is the mechanism of DQ synovitis. What are all the clinical features? Patient may complain of pain on the radial side of the wrist that is worsened by the moving the wrist or the thumb. Sometimes there is a visible swelling over the radial styloid. The tendon sheath may feel thick and hard on examination. Tenderness is mostly acute at the tip of radial styloid. If you press over the radial styloid, the patient feels in pain. Pain aggravates on grasping and raising objects with wrist. A wet lesion and the Finkelstein test is positive. We shall see the Finkelstein test, which is almost diagnostic. Okay. So this is Finkelstein test. It's a provocative test. Provocative test means if you do the test, the pain aggravates and the patient feels pain. It's almost diagnostic for the DQ synovitis. First of all, make a fist with the thumb inside. Now ask the patient to bend the wrist towards the little finger, or clinically what we say ulnar deviation. Make the patient to hold the thumb inside and make a fist, and tell the patient to ulnar deviate the wrist. If the pain aggravates, or if the patient complains of pain, then it's almost diagnostic of DQ synovitis. So, any clinical feature or any clinical scenario, we should have a differential diagnosis. So we will see the differential diagnosis here, and that's carpometacarpal arthritis of the thumb. There you can see pain and crepitus present in the thumb. Crank and grind test we can do to rule out the CMC arthritis of the thumb. Scaphoid fracture. In this, tenderness will be in the anatomical snuff box. Schaffer's fracture. Schaffer's fracture is a fracture of the radial styloid. Schaffer's fracture is a fracture of a radial styloid. And intersection syndrome. Tenosynovitis of the second dorsal compartment involving the tendons of extensor carpi radialis brevis and extensor carpi radialis longus. Usually the pain will not be in the radial styloid region. The pain will be more proximal and on the dorsal part of the distal forearm. Extensor pollicis longus tendonitis of the third dorsal compartment, most common in patients with rheumatoid arthritis or with a direct injury and distal radius fracture. So these are all the differential diagnoses: CMC arthritis of the thumb, scaphoid fracture, Schaffer's fracture, intersection syndrome, and extensor pollicis longus tendonitis, which you will see more common in rheumatoid arthritis. So what are all the treatment goals here? First treatment goal is restoration of normal painless use of the involved hand. Make the patient pain-free. A resolution of inflammatory process so that it will not progress to the stage of fibrosis or stenosing stage. Prevention of recurrence through thorough education. Sorry for the grammatical mistakes here. Prevention of recurrence is the third goal, and restoration of pain-free movements and strength training, because the patient will not be using for the long time due to pain. So restoration of normal painless use of the involved hand, resolution of inflammatory process, prevention of recurrence, and restoration of pain-free movements and strength. So the treatment aspect involved, there's no obvious investigation as such. It's usually a clinical diagnosis where we can do the required test, clinical test like Finkelstein's test, and if it's positive, we'll take it as a DQ synovitis, and the management is usually conservative, such as NSAID and steroid injection. First, we will prescribe non-steroidal anti-inflammatory drugs, usually for 6 to 8 weeks, to reduce pain and inflammation. If the pain doesn't go with that tablets, non-steroidal anti-inflammatory drugs, we'll give a corticosteroid injection. locally into the synovial sheath. So along with that, we'll start physiotherapy management, like immobilization for 2 to 3 weeks. If you start if you start the treatment conservatively, you will ask the patient to take the tablets and give rest to the part. Giving rest to the part, we will call it as immobilization. A thumb spica splint can be used as you see in figure. Along with that, the patient can have cold compression for 10 to 12 minutes over the inflamed area once or twice daily. So immobilization for 2 to 3 weeks is required here. Other modes of physiotherapy are ultrasonic therapy. Here ultrasound is given to the local area for 5 minutes every day for 2 to 3 weeks, and phonopheresis with 10% hydrocortisone. Okay. And gentle active and passive motion of the thumb and wrist encouraged for 5 minutes every hour to prevent joint contractures and adhesions. See, in joints, if you restrict the movement for a long time, there are chances of joint contracture and adhesions. To avoid that complication, patient is advised to do active and passive motion of the thumb and the wrist for 5 minutes every hour. Strengthening and stretching exercises only after the pain subsides. You should not do these strengthening and stretching exercises when the pain is there. Alright. So these are all the rehabilitation exercises that we prescribe to patient once the pain subsides, not during pain. Opposite stretch, wrist flexion, radial deviation and strengthening, wrist extension, grip strengthening, finger spring. Alright. So rehabilitation follows once the pain subsides, not during the painful period. So surgery will be the final treatment once the conservative management fails. Conservative management includes non-steroidal anti-inflammatory drugs and local steroid injection and physiotherapy like ultrasound therapy and phonopheresis. So what are all the indications? Here are unsatisfactory symptom reduction, persistence of symptoms after the conservative treatment, limitations in daily activities due to pain. If the patient is not able to do his daily activities even after the conservative treatment, then we will go for surgery. The surgery here is decompression. We will open the sheath and decompress the tendon. That's the surgery here. So another important aspect is ergonomics. So most of the people will be using computer aids nowadays. So we have got ergonomic mouse. Since using mouse repetitively predisposes to DQ synovitis, so ergonomically there will be a mouse for that one. It will give rest to the thumb. It will prevent extension. Alright. So the bottom line is use ergonomically designed device. Okay. Thank you.